Good evening, everyone. My name is Michelle. I'm a product specialist here at Oculus. Welcome to tonight's clinical webcast, Building a Dry Eye Practice in a Primary Care Setting. You have a text box where you can enter questions. Feel free to enter your questions at any time, and we will discuss them at the end of tonight's webcast. Our speaker tonight is Dr. Lisa Hamilton. Dr. Hamilton graduated from the University of Houston College of Optometry, magna cum laude, in 1997. She moved to Denver immediately after graduating and accepted a position at the Dischler Laser Center. She became the center director for the Dischler Laser Center in 2000. In August 2002, Dr. Hamilton started her own practice located within a Pearl Vision and has now expanded to 3 Pearl Vision locations. She was extremely interested in medical model and practicing full scope optometry. Over time, she brought in diagnostic equipment such as retina imaging, OCT, color DX, meibography, topography, threshold visual field, and anterior segment video capability. In 2018, she started focusing on ocular surface disease and brought in iLux, tear care, and LipiFlow into her practice. In November 2020, she added low-level light therapy and IPL. We are honored to have Dr. Lisa Hamilton share with us how to implement a dry eye specialty clinic in a primary eye care setting and explain how the OCULUS Keratograph has played a key role. Welcome, Dr. Hamilton.
Thank you, Michelle. Welcome, everyone. I'm honored to be speaking with you tonight. I've had an interesting journey with bringing ocular surface disease into my practices. I became interested in dry eye over 5 years ago, but had trouble implementing it into our practice culture. I bought treatment devices that sat around collecting dust for years. In March of 2020, we created a dry eye clinic implementation plan with the assistance of Tear Science during our LipiFlow training, and I'm happy to report that we are now doing so many treatments that we converted what used to be my office into a full-time treatment room and hired a full-time treatment specialist. She consistently averages 6 to 8 treatments per day, 5 days a week, including thermal MGD treatments, low-level light therapy, including red mask for gland rejuvenation, blue mask for blepharitis, and IPL. I was just informed today that she's booked out through the end of April. My goal here is to share with you what has worked in our practice, what obstacles we encountered, and how the OCULUS Keratograph has played a key role. For the presentation here, I am a paid speaker for Oculus. I have learned from experience that when we bring in new diagnostic equipment or want to make change in our practice or change our protocols, they generally fail without a strong foundation in place. These are the basics for our foundation. I will review each of them in the upcoming slides. Basically, we want to identify the dry eye patient, diagnose all components of their ocular surface disease, recommend treatment options, monitor efficacy, and make modifications if needed. And I cannot stress this enough, set realistic expectations for the patient. Dry eye is chronic and multifactorial, and we want them to know that this will be a long journey. We've set a goal in our practice to identify every patient who has ocular surface disease. There are several ways to go about identifying the OSD patient, and you can be successful with any of them. I'll share my experience with each. So one option is to ask every patient to complete a questionnaire. One is to offer a dry eye screening for a fee. We could just do meibography on every patient, or we could measure tear breakup time on every patient. In our practice, we first decided that we would ask each of our patients to complete a survey at check-in. In our practice, we found that approximately 50% of our patients have MGD with gland atrophy, but only 20% are symptomatic. So with this method, we were missing about 30% of our patients with MGD, and we were finding that it was slowing down the process at check-in. So we stopped doing that. Next, we decided to offer dry eye screening for a nominal fee at check-in. The negative thing that happened is our Optos and Wellness package conversions decreased, and only about 5 patients per week opted in for dry eye screening. If you're going to offer a dry eye screening, the OCULUS Keratograph has great tear film imaging and meibography, which will help with diagnosis and patient education of the majority of the patients who opt in. But as I mentioned earlier, asking patients to pay for a dry eye screening at the same time we're asking them about wide-angle retina imaging was causing confusion at the front desk. We do use the Oculus, but no longer for dry eye screenings in that way. Another option would be to just get meibography images on every patient. This is very effective for identifying patients with long-standing meibomian gland dysfunction who are starting to show signs of atrophy, and you cannot argue with the images. So it's very compelling for the patient. The billing experts will tell you this is not a good practice because payers don't currently cover it, but they expect you to charge the patient when you do it and have medical necessity for doing it in the first place. And then it does tend to catch the disease in the moderate to late stage, and you'll miss the early stage when the glands are blocked, but there's not yet any atrophy. And then just what meibography is, it's near infrared imaging of the meibomian glands, and it does have a category 3 code, but again, the payers are not paying for it right now. We could just measure tear breakup on all patients, and this may be the best way to do it. This allows the practitioner to indirectly measure how much oil is in the tear film, and since blockage occurs before atrophy, catching the NGD in this stage and starting treatment now gives the patient the best possible outcome. Identifying a reduced tear breakup during the vision exam establishes medical necessity for the meibography and for a patient to return for ocular surface disease workup, tear film analysis, meibography, and any labs you want to perform, osmolarity or inflammadry. Also, it's easy to add to your vision exam without affecting clinic workflow. And okay, so next steps. You have taken the first step and established a method to identify your patients with dry eye. Whatever method you choose to identify your patients, if you are doing it consistently, you are going to identify several patients with dry eye disease. So now that you've identified your patient, what now? The next step is to do a full diagnostic workup to determine what type of dry eye they have and all treatment methods recommended for them. We schedule our patients back for a billable medical office visit titled Ocular Disease Evaluation. Feel free to get a screenshot of this slide if you like, and this is being recorded so you can always look at it later, but these are all the elements of our ocular surface disease workup. One way to do this is to do all of this at the slit lamp. In our case, we modified our electronic health record and made an OSD tab in there. We bring a scribe into the room who's also our treatment specialist. The scribe helps the doctor with necessary charting, and she stays in the room to answer further questions the patient has. She discusses financing options and facilitates scheduling of treatment. She also explains the use of any lid scrubs or pre-treatment medication needed, prints out prescriptions, reviews instructions with the patient. In our office, we noticed that we had greater success when we could show the patients what we were seeing. So if we just look with the slit lamp and tell the patient what we see, that's one option, or we can image the patient and show the patients their images. The OCULUS Keratograph is a great tool to achieve this. With the Oculus, the technician can capture the images and video in the pretest room and then load them up with the viewing software in the exam room for the doctor to review with the patient. Our acceptance rate for in-office thermal treatment doubled when we started showing the patients what we were seeing. Photo and video documentation also provides comparative analysis over time to evaluate how well the treatment is working. So as mentioned before, having tear film imaging and meibography is key in documenting patient condition and with patient education to facilitate the compliance with treatment recommendations. The Oculus has other uses as well. I'll just kind of go through these with you. So meibography is one. Lid imaging, great for documenting blepharitis. Tear film and lipid layer analysis. the non-contact tear breakup time, or non-invasive tear breakup time, your redness score, that's the measure of inflammation, tear lake height, this is a great way to measure tear volume, fluorescein corneal staining imaging, we'll show you some examples of this later, the images are very high resolution. And then additionally, you have topography and specialty contact lens assistance. All right, so here is an example of mybography with the keratograph. It's an assessment of gland structure. It looks at the meibomian glands for torsion and dropout. Keep in mind that you can have blocked glands, a tear breakup of 1 second, a very symptomatic patient, but normal mybography images. If you see dropout, that's an indication of long-standing blockages and inflammation in the meibomian glands. When getting images, one challenge we have is everting the lids. The OCULUS LidStick helps the technicians manipulate the lids without having to physically touch the patient, which is especially important when practicing during a pandemic. The lid sticks are single use and individually wrapped so the patient feels comfortable with sanitation. It also avoids having the technician's thumb or fingers in the image, which I found to be a plus. Mybography with the keratograph measures the amount of gland atrophy and then scores it on a scale of 0 to 3 in the crystal tear report. We will review the crystal tear report later in the presentation. So tear film imaging has a bill code, but it's not covered by the payers right now. There's no reimbursement for this type of code, so the patient generally pays for it. In the future, mybography and tear film imaging might have billable codes covered by payers. John Rumpakis and other billing specialists who do coding and billing would probably advise you to always charge the patient when you do mybography or tear film analysis, and then report it to the payer so they can track utilization. Assessment of tear quality. Quantity. So this is great. I can't tell you how many times with the slit lamp, I'll be calling off to the technician that the tear volume is low or reduced or minimal. So this allows us to, I can show you here. Well, my pointer isn't working here, but as you can see from this little blue area at the bottom of the screen, you can measure the tear lake height and it'll give you a measurement in millimeters. And I found that to be much more accurate and trackable than me just writing down that the tear film is reduced. And then we can also assess tear film quality. The keratograph provides 3 assessments of tear quality. One is the tear breakup time, and the other one is tear film dynamic. That looks at the number of particulates in the tear film, which is an indicator of irritation or inflammation. And the third one here is lipid layer, and that will show the color in the tear film, which can be used to assess the lipid volume, that top layer. The non-invasive keratometric breakup time shows the time and location of the breakup. The graph shows the percentage of tear film breakup over time. The software gives a classification of 0, indicating a stable tear film, 1, unstable, or 2, very unstable. If there's no breakup after 13 seconds, the map will turn green. Let's see if I don't think we can zoom in here very well, but down in this bottom lower square, you can kind of see breakup first is 3.6 minutes, and then right underneath that breakup average is 8.55 minutes. So that'll show the provider the time frame of the very first area of evaporation and then the average. And then you can definitely use that to track a patient over time as they go through treatment. And that's what this graph here is showing. The one on the far left was showing that their tears were breaking up very quickly. Then in the midsection, it's mostly green, still with some breakup. And then on the far right, it's just about all green. So that shows the patient and the doctor the efficacy of the treatment plan. For the lipid layer, we want to look at the color pattern. And white, if these rings here are white, that indicates that the layer is thin, the lipid layer, the oil layer, generally under 60 microns. If it's yellow, it's a moderate thickness, probably around 90 microns, and blue indicates a thick lipid layer around 180 microns. I'm just going to play a little video here for you so you can see what that looks like. This is an example of a thick lipid layer where you can see all colors of the spectrum. Okay. And then the next one, this is video of a normal lipid layer. Mostly going to see browns and yellows here. And then this last one, video indicates a thin lipid layer, really just seeing mostly white. And then tear film dynamic. This evaluates the amount of particulate in the tear film, which could be an indication of irritation with the eye. The speed at which the particulates move also allows us to make conclusions on the viscosity of the tear film. Remember, if you see a lot of particulate, plugs are not advised due to the amount of inflammation. You'll want to wait until there's less inflammation before you do punctal plugs. This one here is an example of a low amount of particulate. If you watch the video, you just see the little areas of particulate moving around. We'll have an example here of moderate particulate. Get that going. Okay. So the conjunctival redness scan, just like the tear volume, when I'm evaluating at the slit lamp and I'll say, oh, they're grade 1 injection or grade 2 injection, I really like having these images. This will help me look back over time and see where the redness was and how much there was and see if the patient is improving. This is an example here of how the Oculus will grade it. So the far left would be grade 0, no redness at all the way from grade 1 to grade 4. And I love lissamine green for dry eye evaluations. Lissamine green stains dead and devitalized cells on the bulbar conjunctiva, which is great for early detection of dry eye. Lissamine green is also a great way to determine the line of marks on the lid margin and look for lid wiper epitheliopathy, or LWE. So these are some images of, if you look at the upper left-hand corner, that line of marks is coming across, and then those two thick areas are areas of lid wiper epitheliopathy. See if I can, here we go. I think I figured out how to use this pointer. So the LWE area is right there and right in there. And then this staining margin here is just the line of marks. This is showing two different, this on the left here would be a fairly normal line of marks, and this is a very thick line of marks. It can serve as a fast and simple indicator of meibomian gland dysfunction. The marks line, by definition, is a row of cells located on the upper and lower eyelid at the junction of the keratinized eyelid epithelium and palpebral conjunctiva. As evaporative dry eye progresses, the line shifts. It moves from behind the meibomian glands to partly touching the glands to transecting the glands, and then, in the worst case, all the way in front of the glands. And then this is just another image of the lid wiper epitheliopathy. That occurs when there is friction during blink, and the lid margin conjunctiva and ocular surface are rubbing against each other. It's an indicator of reduced tear volume or poor mucus layer, and it can also occur with contact lens wear. These are some images of the fluorescein staining with the Oculus. I currently have a slit lamp camera on my TopCon slit lamp, and these images here with the Oculus actually do better than my slit lamp camera does. And then corneal staining can be graded on a scale of 0 to 4. And in addition to the nick butt option, the Oculus, you can also capture video with fluorescein to show a traditional tear breakup analysis and show the patient if they're like a partial blinker. And then as you can see up here on the top, you can see the grading scale of grade 0 with the SPK all the way over to severe or grade 4. Lid light closure is a good way to explain to the patient how well they close their eyes at night. This image here, I tried to just have one of my staff members demonstrate this, so it didn't come out exactly the way I wanted to. But if the patient isn't closing their eye completely, you'll actually see some fluorescein coming through the lid margin. And that's a great way to show the patient that they really don't close their eyes completely. The traditional way to do it is to just hold the pin light or a transilluminator up to the eyelid and then see how much light is leaking out. That's an indication that the patient's probably not closing their eyes completely at night while they sleep and might benefit from avoiding ceiling fans or using maybe they should use some ointment or even wear an eye seal goggle if they're waking up in the middle of the night with dry eye symptoms. If we can get this to advance here. Okay. And the Oculus also does a really nice job at taking images of the eyelid margin. So the image on the left is showing this waxy buildup here that we see with Demodex. And in our office, we use blue light, low-level light therapy to treat that. But you can also use BluffX or lots of topical treatments. But it does really show the patient why they need to be treating this. And the Oculus can also be used with the gland evaluator. We use the gland evaluator to see how much oil is coming out of the glands. At our office, we use the slit lamp still for this part, but in theory, you could try to have the technician do that in the pretest room, capture a video, and the doctor could review the video with the patient. And it makes a great slit lamp camera. So this is the crystal tear report, and this is something that the Oculus will generate, and we can print this out and give it to our patients. And it's customizable. We can basically customize it for aqueous deficiency, meibomian gland dysfunction, and it'll put some images up here, and then you can print that out and give it to the patient. And this is just showing some examples of how it's customizable. You can tell the patient, with this condition, make sure you're drinking water, you're using Oasis Tears, taking supplement, we're going to do punctal occlusion or whatever your treatments are. So this is all customizable. So treatment options. Now we have our diagnosis. We need to create a treatment plan for our patients. Obviously, if they have blepharitis, we need to clear this up before performing any in-office thermal treatments. Do not want to heat up and press on inflamed eyelids. And then meibomian gland in-office thermal treatments. Patients generally pay for this out of pocket. If there's aqueous deficiency, we can do punctal plugs or artificial tears. And if there's inflammation, we can prescribe steroid drops or cyclosporin. And we definitely want to hold off on any plugs, as mentioned before, until the inflammation is resolved. Causes of blepharitis. So we've got Demodex as the main cause. and staph bacteria is a cause as well. This stuff right here, this waxy buildup, is really thought to be dead Demodex mites and waste product that occurred deeper in the lash follicle. And then as the lash grew out, this junk is just here on the lid margin. So this is a picture's worth 1,000 words when you're trying to get a patient to be compliant with treatment recommendations. So in our office, as I just mentioned, we treat blepharitis with the iLight, blue light, low-level light therapy mask. The patient comes in for 4 20-minute treatments, spaced about 2 or 3 days apart. We also have them do lid scrubs and hypochlorous acid at home. And before we clear, oh, sorry, hit the wrong button there. So before we clear them for any in-office thermal treatments, we need to make sure their eyelids are clear. In severe cases, if there's lots of crusties on the lids, you want to use the BluffX or something like that to really get that biofilm off of there. And if there's severe inflammation, sometimes we'll prescribe a steroid ointment or doxycycline or azithromycin for eyelid inflammation and get that cleared up before any thermal treatment. Here's sort of an overview of all the thermal treatments, and I'll cover each of these in the upcoming slides. We have all of them in our office except for the MIBO. So the iLux by Alcon, that's a handheld device that the doctor or technician can operate. It's easy to transport between offices or exam rooms. The cost is roughly $12,500 for the unit, and disposable costs are roughly $295 for a bilateral procedure. The person performing the procedure can see the glands through the magnifier that is attached to the unit. So right here, there's a magnifier that the operator looks through. The light will turn green when the glands are at the appropriate temperature, and then the operator will just press a button and start expressing the glands, watching through the magnifier to see what's coming out. Generally, we treat 3 treatment sections on the lower lid and 1 on the upper lid, and the same disposables used for both eyes. So treatment for MGD with IPL. This is a fairly newer concept, perhaps. We learned about the benefits of IPL for MGD from dermatology. Many patients treated in dermatology offices for rosacea reported improvement in their dry eye symptoms. So how does this work? The mechanism of action is believed to be multifactorial, a couple things. So one, thermal. The IPL will heat the gland, so having a thermal softening and liquefying effect on the meibum. It also pseudo-cauterizes the microvessels, reducing inflammation pathway to the meibomian glands. And we believe there might be an antimicrobial effect. It helps kill the bugs causing the inflammation in the first place. So watch for new devices coming to market geared for ophthalmic use. Currently, one of the instruments shown on the top, that's the one we have, does not require any gel or corneal protective eye shield, but it only treats the lower eye, it only treats below the eyes. So we only really get the lower glands. The other method shown here, they have to insert this cornea protectant shield, and that's what this little peg is here, and they have to put gel on the lid, but then they can get the upper lid and the lower lid. Tear care. Tear care is compact, works for all patients, easy to transport. The heat stays on the lids for roughly 15 minutes, and the heating element attaches with these little adhesive sticky things here. And the technician or the patient can adjust the heat right here with this handheld device within reason. And it does require manual gland expression immediately following removal of the smart lids. These guys are called smart lids. So the doctor has to be fairly on standby, knowing when the patient's going to be ready, when that 15 minutes is up, and then the doctor would come in the room and do this manual gland expression at the slit lamp. TearCare is going for insurance reimbursement right now, so they're currently working on that. So stay tuned for more information on that. Instrument cost is roughly $5,000, and disposables could be anywhere from $350 to $500 bilateral, depending on how many you purchase and what plan you're on. And this is the bill code for the procedure. MIBO, so MIBO ThermoFlow. So this one's pretty cool. It's completely tech-driven, no disposable cost. You can put it on a movable cart and potentially move it around from room to room and possibly even from office to office. There's two instruments. One of them is a smaller unit, and then there's a larger unit. So the cost is anywhere from $8,500 to $12,000. Doesn't technically do gland evacuation, but there is a mild gland expression. So there's a little bit of pressure that's put on right there when the techs do it. So it'll just sort of gently ease out some of the liquefied meibum. But if there's true hardening, if there's a lot of hardening in there, it may not express it as well as the true gland expression would, or the LipiFlow. All right, and then low-level light therapy. So the Equinox low-level light therapy is a non-invasive meibomian gland dry eye treatment for all patients. Does not require any gel. Gets the upper and lower lids simultaneously using direct and indirect photobiomodulation. During a typical 15-minute application. This is cool because it's more than just thermal treatment. The wavelength of the light stimulates the meibomian glands to improve functionality. So it actually activates the ATP in the mitochondria. It's now available through Marco. They have two units. One unit has a head on it that can also do IPL, and the other unit is just for the mask. So and they have different pricing structures. I think 25,000 to 50,000. So you have to know before purchasing one of these if you want the IPL option or not. If you buy the instrument that does not have IPL with it, you won't be able to add that later without getting a different instrument. The masks, the way the disposables work is the masks are preloaded with a certain number of treatments on them, and the machine keeps track of how many treatments each mask has done and will notify you when you're starting to get low and let you know that it's time to buy another mask. And then in our office, we do manual gland expression immediately after removing the mask. So this could be, that really helps with helping to evacuate the glands. You can also do it just as a monotherapy without the gland expression. Just probably wouldn't be quite as effective, but it has been shown to be effective as monotherapy as well. And then LipiFlow, the original gold standard. This unit is not as easy to move as some of the other devices, and transporting it between offices might void the warranty. So we placed one at each office. The activator cost just went up, but the company is offering a rebate based on volume to reduce the cost of the activators. Let's see here. And then obviously punctal plugs in case of aqueous deficiency. And sometimes the aqueous is deficient because the tears are evaporating. So oftentimes patients with evaporative dry eye also have low tear volume and would benefit from punctal plugs. When choosing a plug, patient education is critical. The silicone plugs can be more noticeable to the patient, and in some cases they can sort of migrate down to this common canaliculus area here, which is, it could cause some epiphora, could block both the upper and lower drains, and that could require surgery through the nose to get that out of there. So you'll definitely want an informed consent if you're doing a silicone plug. I really love these extended duration plugs. So we do a lot of those in our office. They last about 3 or 4 months. The patients cannot feel them, and generally they don't feel them, and there's no risk of them getting lodged somewhere and having to be surgically removed. And if it's allergy season, I think the patients do better without plugs certain times of the year. So I like that I can do this sort of as needed. So treatments for inflammation. So you can obviously do topical steroids. We can do oral tetracycline or cyclosporin A for, long-term. And we often will use a compounding pharmacy if the patient's insurance isn't going to cover the Restasis or whatever type of cyclosporin we're using. You can get that at a compounding pharmacy for less money. All right. So once we have made a diagnosis and initiated treatment, follow-up care is needed to monitor for efficacy of treatment. We've got to stress to these patients, they're not going to just get one thermal treatment and then be cured. This is a chronic progressive condition, and it will be a journey. We may have to modify treatments or make modifications to our treatment plan, and they need to know that punctal plugs or Restasis or other treatments may be needed in addition to the thermal treatment. We don't want them to expect the LipiFlow or whatever, or your tear care or your iLux. We don't want them to expect that to solve all of their problems with one treatment, and don't want them to think that that treatment didn't work. So we always explain that the thermal treatments are treating the meibomian gland blockages, but they may also have inflammation that needs to be treated, and they may also have an aqueous deficiency that needs to be treated. So we're very, very proactive with explaining all of that up front. So I just have some dry eye statistics that I looked up for us. Dry eye disease is among the most common ocular condition we encounter. It often reduces the patient quality of life and work productivity. Evaporative dry eye caused by NGD is a component in over 85% of all dry eye cases. And a survey conducted by the AOA in 2017 found that over 16 million Americans, twice as many women than men, reported dry eye symptoms, and 6 million of them reported that their eye doctor did not diagnose them with dry eye disease. Before we implemented dry eye clinic in our practice, we were diagnosing at best 10% of our patients with dry eye or ocular surface disease. And now that we are actively looking for dry eye, we're finding that approximately 45% of our patients in Colorado have some form of dry eye. We were doing our patients a huge misservice by not actively looking for it and diagnosing it. Some of the most difficult conversations I've had so far is reviewing meibography results of patients who have been seeing me for years, and now I'm just saying, oh, hey, by the way, you have 80% gland atrophy, and now we should do some thermal treatments, but we're catching this a bit late. And they're saying, hey, Dr. Hamilton, why didn't you tell me this? I've been seeing you for 5 years or 10 years. So that really has been some of the most difficult conversations that I have had. Okay, so now you're excited to bring ocular surface disease into your office, right? Here are some things to consider. Once you have a plan of action, think about how you will work this into your practice flow. Will you need to set up a separate treatment room, or will you use an exam lane? Will you need to hire more staff? What diagnostic and treatment equipment will you purchase? What goals will you set, and how will you measure success? Will you modify your appointment book to create designated exam spots for ocular surface evaluations? So this image right here was taken when we were training our staff to use the OCULUS Keratograph for meibography. I volunteered to be a patient for the technician to practice on. I had no dry eye symptoms whatsoever. I was a bit surprised when my tech said, "Hey, Dr. Hamilton, I think you might have some gland atrophy." In that moment, I became aware of how prevalent MGD is and how often I was failing to diagnose it for my patients. So that is our presentation tonight, and I am available for answering some questions here, and this is my email address. If you have any questions for me and want to email me later, I'd be happy to answer your questions anytime.
Thank you, Dr. Hamilton. Just a reminder, on your GoToWebinar screen, there is a text box where you can enter any questions you may have. If you missed part of the webinar or there's something you want to go back and review, you will receive a link to the recording in the next week. Okay, we do have some questions from the audience, and one of them is, are you staining with fluorescein or lissamine green? And if so, do you have a preference?
Yeah, so in the ocular surface workup, we do all of them. Let me see if I don't want to put you through too much craziness here, but let me go back to the ocular surface slide. But to identify my dry eye patients, so during the vision exam, I just do fluorescein. And then even though the medical billing and coding experts don't recommend doing mybography on all patients, we do. So that's just something that I review with the patients during their vision exam. I review their mybography with them. I don't charge them for it. It's not anything we're asking them to pay for up at the front desk. And then I put some fluorescein in and look at their tear breakup time. If we identify that they have likely some evaporative dry eye, then I do bring them back for that full ocular surface workup. Basically, during that, we look for lag ophthalmos, lid-like closure. We then put lissamine green in. We look for conj staining with lissamine green, and then we look for, at the line of marks, we look for any lid wiper epitheliopathy. So basically, we use both stains, and then we put the fluorescein in and also look at the tear breakup time and look for any corneal staining. And then we get the gland evaluator out and evaluate the glands to see how many clear secretions are coming out.
Thank you. Now, you had described that you do mybography on all patients, or you do mybography images. And if you notice atrophy in the glands or any abnormal findings with the mybography images, what is that conversation you have with the patient to have them come back for a dry eye evaluation? And do you have that conversation, or does your specialist, your dry eye specialist, have that conversation?
So I'm the one having that initial conversation. I'm usually in the exam room alone. I don't quite have the luxury of having a scribe with me at all times. I do always have a scribe, though, for the ocular surface evaluation. So they say a patient's coming in for a routine vision exam. My technicians do the pre-testing. They do the ancillary testing, the pupils, the extraocular motility, cover test, and visual acuity. And then they load up all the images on the screen for me, and then they usually exit the room. So I'll walk in, introduce myself, review their wide angle retina images with them. If we did OCT, review that with them, and review their mybography images and their topography images with them. And then if there's any gland, and really reviewing their glands starts a great conversation, because they'll say, what are those and why did you image them? And I'll say, well, the meibomian glands are responsible for putting the oil into the tear film, and 85% of people with severe dry eye have problems with these glands. And if they get blocked, they will start to atrophy, and that atrophy is non-reversible. So we want to know if it's happening to you, and if so, we want to intervene and try to prevent a progression. And then I'll start asking the patient, are you having any dry eye symptoms? And then I'll usually jump up, roughly around that time and put some fluorescein in, or whenever I get to that point in their slit lamp exam where I'm ready to put the fluorescein in, I'll sort of remind them that we're evaluating the tear film, and I'll trace that back to the meibomian gland images that we looked at when I first walked in.
Thank you. All right. Who makes the blue light mask?
Yes, that's a company called Espanzioni from Italy, and you can get it through Marco. Marco sells the instrument. And like I said, there's two versions of it. The one that does the masks, you can order a red mask, blue mask, and a yellow mask. The blue mask is antimicrobial, so it's great for treating blepharitis. It'll kill staph and the Demodex. And it really gets, if you think about it, when we do lid scrubs for killing Demodex mites, they're deep. They're down in the glands. They're in the hair follicle. How effective is that really at getting them? So the blue mask is great. It gets the energy gets right down there and really kills them. You still have to mechanically remove the scurf and the buildup, though. So you still have to do the lid scrubs and get that stuff off of there, or do a BlephX and get that off of there. The red mask is, and I didn't really mention this before, but the red mask is a great non-invasive way to treat chalazion. So how many times do we have a patient with chalazion and we end up referring them out to the ophthalmologist who just, cuts the gland out altogether? We can do 4 red light treatments, and usually it'll be resolved, it'll be gone, and we'll save the gland. So I really like the red mask and the blue mask. I like the IPL, and any patients with rosacea definitely benefit from that. And then the yellow mask, I don't currently use too much. It's for inflammation. Actually, I don't use it at all. We didn't buy that one. It's used for inflammation. It would be very helpful for patients after a blepharoplasty, but that's just not a large enough, percent of my patient base for me to have invested in in a yellow mask. So you have to buy each mask separately. If you buy a red mask, and then the price will depend on how many treatments come with it. And
Great. Thank you very much. And with your younger patients, do you see them presenting with MGD due to digital device use? What are some trends you're seeing in younger patients?
Absolutely. And that's another thing we talk to them about with their maintenance therapy is, keeping the lid margins clean and exfoliated, but also blinking exercises that, we try to tell them the 20-20-20 rule. So for every 20 minutes, do 20 seconds of blinking and refocus your eyes 20 feet away, because we all just tend to sit and stare. And, that lack of blinking, the oils in the meibomian glands will harden up and cause some atrophy.
We have another question asking, if a patient is asymptomatic and fails your screening, how do you get them to return for the ocular surface workup?
So if they're asymptomatic, all I can really do is educate them, and then it's up to them to return. And not all of them do, but most of them will return. I'll tell them that the ocular surface workup is covered by their medical insurance, and it's usually going to be their specialist copay. Do always explain that to them, though. Sometimes they think it's a free follow-up, and there's really, it's not that. So, but yeah, some of them won't come in, or if they're not symptomatic, they won't pay for treatment. And it's not really my job to make them do it. It's really just my job to educate them diagnose them properly and educate them. And then even if they've got some gland atrophy, but they don't want to do anything, then I'll say, okay, we can just monitor this. And when you come in next year, we'll image your glands again, and we'll check to see if there's been any sign of progression in gland loss. And then I'll tell them what symptoms to watch out for, and say, if you start noticing these symptoms, come back in sooner. And sometimes we'll send them home, with the traditional Bruder mask and things like that. But really, if it depends on how hard those oils are in the glands, and if it's just mildly thickened, then those can be effective. But if it's like concrete in there, it's going to really take an in-office treatment with gland expression.
Thank you. And do you find that there are regional or environmental differences in the common dry eye causes or symptoms?
I don't know if I can answer that. So I'm just in Colorado, and for us here, the air is really dry, right? We have low humidity. So when patients ask me, is this just a factor of Colorado? I'll say, well, if you had great oil, you'd have your tear breakup time would be maybe 10 to 13 seconds, and the dryness wouldn't bother your eyes nearly as much as if your tears are evaporating in 1 to 2 seconds. So I'll say that you're definitely going to feel better if you're in a more humid environment, but your glands still might be atrophying away. And a lot of patients too, just to come back to that previous question about the asymptomatic patients, I'll say you might not be symptomatic now, but why wait until you're having symptoms? You know, if your dentist tells you you've got a failing, filling and you're going to need a crown, you don't really wait until your tooth is killing you before you go in. So I tell them it's more about prevention. And if they wait until they've had too much gland atrophy, it might be too late. And then once they're symptomatic, there'll be less we can do because we can't get them back once they've atrophied.
We also had another question that you take images of the meibography, you bring them back for a follow-up. What are the follow-up exams that you do with the keratograph?
Yep. So when we use the keratograph just for meibography on their vision exam. And then we review their, like I said, we review their meibography with them in the exam room. And there's a image management software that we can look at it with them in the exam room. And then with the tear breakup time. So that if we identify the patient has a problem, then we bring them back. I love to have the technicians just go through, the keratograph has some programs you can even set up. The technicians will go through the nick butt, the bulbar red, the fluorescein staining. So they'll do all of that at the keratograph, take the images, and then I can show the patient that during the ocular surface disease evaluation. So we'll show them their eyelid margin if it does or doesn't have blepharitis. If it doesn't, we'll celebrate that. We'll say, some people have these little mites that live in their lashes, and guess what? You don't. So that's good news for you. And then we show them their tear height, their tear volume. We show them how red their eyes are. We look at their tear breakup time, and then I just sort of at that point will dry their lid. Then I'll bring them to the slit lamp. I'll dry their lid margins off, use the gland evaluator. I'll tell the patient that I'm just putting a little bit of controlled pressure on their eyelid. We're testing 5 glands at a time, and this amount of pressure should cause oils to come out of the glands. And I'm going to call off to the technician how many glands are secreting or pooling in each section. So if I'm call out 0 out of 5 glands on the left eye temporal, and then I'll move to the central and I'll say, okay, we've got 1 gland pooling here out of 5. That means 4 are blocked, and then move to the nasal. So the patient's hearing all of this. And then at the end of that evaluation, we bring back up their meibography again and show them their gland structure. And then I'll tell them that they would, I'll lay out a treatment plan for them. And then I'll tell them that Molly, who's in the room with me, or Jade, or whoever's in there, I'll say that this person's going to answer all their questions, and then I'll be back if they've got more questions for me. And then I usually just leave, and then the technicians take over.
Thank you, Dr. Hamilton, for that great presentation and the great question and answer session. That's all the time we have for tonight, and thank you everyone who sent in questions and for joining us. Thank you again so much, Dr. Hamilton. And was there anything else, any final thoughts you wanted to leave with the audience?
No, just this is way more prevalent than you might think, and if you really start looking for it, you'll start seeing a lot of it in your patients.
All right, this concludes the presentation, and on behalf of Oculus, good night everyone. Thank you.